What's really caught our eye is there's been some recent data showing that when people in fact take GLP-1s, let's say for diabetes, what we're learning is that if they take GLP-1s for diabetes or obesity, they have a much lower risk of developing depression. They have a much lower risk of developing cognitive problems. So in other words, that gives us reason to believe that they're preventative, but also indirectly is validating a hypothesis that maybe GLP-1 dysregulation is not just associated, maybe it's causative. Because we know that mental disorders are heterogeneous from a causal and pathoetiologic perspective. Maybe this is one of the suspects in the causal category.
Our recommendation is that we move to a more just systemic definition of personality disorders, moving away from the individual labels and defining the disorder in a very personalized way. So if there is moderate or greater impairment, then the pathological personality traits that characterize your particular patient are how you sort of fill in the colors of your particular patient. So that's kind of where we are. Ironically, the new guideline that's coming out for borderline encourages clinicians to use the term borderline and to educate patients and families about what we know about borderline personality disorder. And we know a lot. So the big contribution of the new guideline will be an update in terms of the literature and the research that's been done since 2001.
There's no FDA-approved psychedelic at this point, so this is still an area of research. But one of the biggest questions would be, can we give someone who already has a substance use disorder a psychoactive substance to treat that also has misuse potential? One of the most unique aspects about psychedelics is out of the biggest classes of psychoactive drugs that are used by humans, they have the least addictive potential. And there are a few reasons for that, potentially. One is that psychedelics are not reliably pleasurable. So, sometimes people associate psychedelics with euphoria, but for many people that doesn't happen. They're not euphoric. They actually find it to be quite a challenging experience, even if it is therapeutic.
It is important to differentiate them because the treatments do differ for most of them. So, body dysmorphic disorder is characterized by repetitive thoughts, obsessions, preoccupations, but it's about appearance. It's about perceived flaws or defects in one's physical appearance. So thinking, I look ugly, I don't look right. Some even think they look monstrous. And the repetitive thoughts trigger repetitive behaviors that are different than an OCD, like compulsive mirror checking or excessive grooming. And you asked specifically about trichotillomania, and that is recurrent hair pulling, but without a triggering thought. So people are pulling out their hair, but it's different than in BDD, body dysmorphic disorder. People can pull out their hair, but it's because they think the hair looks ugly.
The treatment strategies are evolving. We have some evidence that lifestyle interventions like exercise and cognitive training have an effect, but these small effects. There's a new drug called lecanemab, which has been approved by the FDA. It's an anti-amyloid drug, and it's a bit complicated to use, and it does have side effects, but it is considered a disease-modifying drug, meaning while it doesn't improve patients, it changes the trajectory. Instead of going downhill at a steep slope, they're going at a moderate slope.